My name is Sowmitra Das. I am one of the doctors currently working as the Northern Care Alliance in the United Kingdom. Today, I'm going to present a case report. Basically, his name is Lemierres syndrome, and following a streptococcus anginosus pharyngitis. Basically, an unusual case of a forgotten disease. So I'm going to give a little bit introduction, like what Lemierres syndrome is. As Lemierres syndrome is a rare complication of oropharyngeal infection characterized by septic thrombophlebitis in the internal jugular vein. The incidence of this rare disease is only 3.6 cases per 1 million cases per year. Basically, before 1960, it was quite common, but after the introduction of like beta-lactam antibiotics, the incidence has significantly dropped. Immunosuppressions and poor oral hygiene have also been shown to contribute as a risk factor of Lemierres syndrome. Around one-fourth of these cases are attributed to the anaerobic gram-negative bacillus, Fusobacterium, the most commonly occurring species being Fusobacterium necrophorum. Recently, a surge in the incidence of Lemierres syndrome is working the medical fraternity. One of the suggested reasons behind this is the lack of empirical use of antibiotics in the oropharyngeal infection. The progression of the acute infection further from the oropharynx lead to extensive inflammation in the parapharyngeal space and the surrounding soft tissue. Then the extravascular compression from the soft tissue edema combined with spreading intravascular infection leads to venous stasis and consequently forms a thrombus in the peritonsillar vein and internal jugular vein. This gets further complicated as a septic embolus can disseminate it into the other organs, most commonly in the lungs, resulting in end organ damage. So today, the case report that describes an atypical presentation of this syndrome caused by streptococcus anginosus rather than the usual Fusobacterium species, demonstrating the need for broader diagnostic suspicion. It also highlights how the involvement of a multidisciplinary team ensures the successful treatments and follow-up of this rare but serious condition. So a 42-year-old male patient presented to the emergency department with complaints of fever and sore throat for over 1 week without any therapeutic relief with conservative management. He also reported a gradual development of difficulty swallowing. He denied any associated cough, chest pain, or shortness of breath. His social history was unremarkable, with no unwell contact or recent trouble. He had no significant or relevant past medical history. The initial observations revealed a body temperature of 39.8 degrees centigrade with a tachycardia of 1.102 beats per minute. The initial examination revealed redness at the back of the throat without the presence of enlarged tonsils, peritonsillar abscess, or quinsy. Breath sounds are normal vesicular breath sounds without any other sounds were found. Infection markers are raised, like neutrophilic leukocyte disease, with raised procalcitonin and elevated CRP levels were found in blood parameter. Marked neutrophilia and thrombocytopenia indicates a possible septicemia. Blood culture were sent for analysis. The impression of the overall clinical picture at this stage was pharyngitis. The patient was started on benzyl penicillin 1.2 gram 4 times a daily. This is the blood picture shows like marked neutrophilia, white cell count is 26.7 into 10 to 109 per liter, and neutrophils is 124.5, platelet count is 71, and CRP level is also getting higher, and procalcitonin level also 3.14. So that indicates severe infection and possible septicemia. Next. So blood culture from 3 days later showed growth of gram-positive cocci in chains, like streptococcus anginosus. During this period, the patient kept on having regular temperature spikes, and based on the culture sensitivity and ongoing pyrexia, he was switched to a vancomycin. The impression after discussion with the microbiology consultant and team was that the patient might have a deep-seated infection or intra-abdominal collection. However, a negative CT scan of the abdomen and pelvis ruled out any intra-abdominal collection along with clinical assessment. The absence of peripheral stigmata of infective endocarditis or any cardiac murmur, and the negative bedside transthoracic echocardiogram showing no images suggestive of vegetation ruled out infective endocarditis. The clinical examination of the back of the throat showed the absence of uvula deviation and swelling in the peritonsillar area and soft pelage, which ruled out the peritonsillar abscess and quinsy. 2 days later, the patient have developed swelling at the left anterior neck with mild tenderness. The examination revealed matted left anterior cervical lymph nodes, mildly tender, firm in consistency, mobile, not attached to the underlying structure, the biggest measuring approximately 3 into 4 centimeter. With worsening symptoms and still ongoing pyrexia of unknown origin, he was switched to IV clindamycin 600 milligram and venjatin penicillin 2.4 gram, both 4 times daily. An ultrasound scan of the neck and the CT scan of the neck and lungs were ordered to rule out any abscess collection, infected lymph nodes, or thrombophlebitis. Neck ultrasound showed there is enlarged structure in the left lower neck along with course of the jugular vein, and thrombosis of the jugular vein was suspected. A CT scan of the neck and thorax was done immediately, showing a septic mass in the left internal jugular vein and multiple septic emboli in the both lungs. Lemierres syndrome as a complication from pharyngitis was diagnosed at this point. This is the picture, arrow area shows like thrombus in the internal jugular vein, which is 2.6 into 2.6 into 8.3 centimeter. That is like quite bigger in size. Next. And this is the CT scan of the thorax. So it's right vessel cavity dilation, which is concerning for septic embolization. After consultation with a multidisciplinary team comprising senior clinicians from the microbiology, vascular surgery, and hematology, patient was started on enoxaparin 1 milligram per kg per day, along with aspirin 75 milligram once daily, and continued with the same previously prescribed antibiotics. After 1 week, a repeat CT scan of the neck was done to see the progression of the previous abnormal findings. Regression of the size of the left internal jugular vein was noted. CT neck 1 week post anticoagulation. So there is a thrombus within the left internal jugular vein, which appears smaller in size compared to earlier, measuring 2 into 2 into 6.7 centimeter. You can see in the picture. So patient was discharged from the hospital 2 days later with aspirin 75 milligram once daily for 6 weeks. Oral comoxiclav 650 25 milligram 3 times daily for 2 weeks, and blood thinner apixaban 5 milligrams tablet twice daily. A follow-up planned with the hematology team in 1 month. During the follow-up clinic visit, the patient reported the previous symptoms had resolved without any new complications, and further follow-up in the clinic was arranged in 3 months' time. So the conclusion here is a Lemierres syndrome is a rare yet serious medical presentation carrying a high mortality and morbidity risk. This report presents a case of middle-aged patient diagnosed with Lemierres syndrome secondary to an atypical streptococcus anginosus infection. He further developed pulmonary complications secondary to thrombus formation in the internal jugular vein. This case emphasizes the need for higher clinical suspicion to ensure timely management of this condition. Similarly, it demonstrated how a multidisciplinary approach and appropriate follow-up are crucial in the successful management of this patient. It also highlights the requirement for larger population-based studies to ensure definitive and evidence-based clinical guidelines to reduce the morbidity and mortality from this rare yet serious condition of Lemierres syndrome. This disease also records as high as 12% of cases ending up with long-term respiratory and neurological complications. Thus, appropriate and timely follow-up is crucial for this patient group. In this present case, with a long course of antibiotics and anticoagulation, finally, follow-up from multiple specialties, clinical recovery was achieved. Thank you, everyone.